Thank you very much. My topic is radical resection and ALPPS, and I'd like to thank the organizing committee for inviting me to speak about this subject that belongs to ALPPS. But he was friendly enough to give me the topic because we have conducted a randomized controlled trial comparing this to two-stage hepatectomy, and that will be most of the talk. The majority of patients with metastatic colorectal cancer are initially unresectable, and the resectable patients, 20 to 25% or much more at ALPPS center, should be treated with at least oncological and surgical trauma to reach tumor freedom, parenchyma sparing as much as possible. For a very small cohort of patients, less than 45% of patients, ALPPS or two-stage hepatectomy is needed to reach this goal. Often downsizing chemotherapy is needed, but the role of each method is unclear. Two-stage hepatectomy or portovenous embolization plus hepatectomy is used in multiple colorectal liver metastases when we have a very small future liver remnant. A volume increase of about 40% can be expected within 4 to 8 weeks. But during that time, there is a risk that the liver is not growing enough and tumor progression during the waiting time. Often there are also other medical problems. With this paper, they introduced a new term, kinetic growth rate, and it was 2.4% in this material, and they found that the growth rate below 2% per week had an increased risk of liver failure and death. In this material, 55% of the patients were included in both steps. If we're looking at other papers, looking at two-stage hepatectomy, we see a resection rate between 62 and 75%, but the morbidity is high, 20 to 59%, and the mortality between 0 and 7. Due to these problems, there's been lots of work trying to find other techniques to increase resection rates. The resected patients have a survival rate of about 40% when they are successfully treated. So, in ALPPS, liver parenchyma division is added to the portal ligation. The method is German, and it was first founded by Dr. Hans Schlitt in 2007. And the first paper came out in 2012 with Andreas Schlitzbauer as the first author and Hauke Lang is one of the co-authors. There were 25 patients, and the mortality was high, 12%. It was lower in the patients with colorectal. The KGR, the growth rate, was much higher for ALPPS, and they expected a 75% growth increase in 1 week. A registry for ALPPS was instituted straight away, and the first paper came out in 2014. The success rate was 98%. 202 patients were included, 141 with colorectal liver metastasis. The 90-day mortality was 9% for the whole cohort, so it's higher than the 7 for the two-stage. 27% of the patient has complication 3B and above. There were lower complication rates in colorectal, but still, this technique has been argued against due to these high rates of complications. So, for patients with very low future liver remnant, this method may give hope. A higher proportion may reach R0, and the total surgical treatment period may be shorter due to the more increased growth rate. But a comparison between the two methods were needed in 2014, and at that time, resection rates were decided as primary endpoint. Oncological outcome was uncertain, so we conducted a Scandinavian trial. The catchment area for Sweden, Norway, and Denmark are 15 million people, and during the study period of 2 years, there were 1,672 liver resections performed. 100 patients were randomized, 6% of all of the people. The randomized study compared ALPPS to portovenous embolization followed by liver resection, or ALPPS compared to local resection or ablation followed by ligature or embolization as a two-stage hepatectomy. So the hypothesis was that the growth rate of ALPPS is expected to be higher, and a higher proportion of patients may be resected with the same rate of R0 with no increase in complication or mortality. We included patients only with an FLR less than 30%, but there was no lower limit, so the patient with the smallest FLR were below 10%. They were all examined at liverboard. They should have had stable disease, at least on preoperative chemotherapy, and the primary tumor or extrahepatic disease should be resectable if not resected before. Exclusion was cirrhosis, young age, or significant comorbidity. So this is just a shot of how we randomized the patients. This decision was of course made at the outpatient's clinic when the patient got information about the ability to be randomized. All patients went through a CT or MRI after 1 week, and those who had reached an FLR of 30% were scheduled for second step surgery. Those who had not grown enough did another CT scan after 2 weeks or after 4 weeks. If at any time the growth rate went below 2%, the patients in the TSH group were able to cross over to ALPS as a rescue procedure. And the ALPS patients who didn't grow enough were, of course, didn't have any options but palliative chemotherapy. We expected a success rate in autovenous occlusion group of 65% and 90% in the ALPS group, needing 43 patients in each arm, and therefore we randomized 100. During the study period, we planned or performed 117 two-stage hepatectomies. 10 patients did it as a decision during surgery. They had an FLR above 30%, 2 ALPS, and 8 two-stage hepatectomies. 2 patients missed inclusion, 3 had severe comorbidity, and 2 patients, 1 declined participation, and 1 decided on the traditional arm. So there were 50 patients in each arm. 2 were excluded in the ALPS arm because of the volume above 30 and severe comorbidity, and 1 were excluded in the two-stage group due to progressive disease. No one was lost to follow-up. So the results. The characteristics, as you can see, 72% of the patients were above the age of 60, as you know is a risk factor for bad outcome in ALPS. The BMI was the only thing that differed between the 2 groups. It was a small, slight difference, as you can see. But you can also see that the ASA score and ECOG, which is the same as WHO score, is quite high. There are patients with ASA score 3 and also ECOG 2. The volume of the FLR was very similar in 2 groups, but due to that the patients were larger in the TSH group, the FLR percentage was 1% lower. This did not affect the outcome. The blood values didn't differ, and the time to first intervention didn't differ between the group. The need for downsizing chemotherapy was the same, and the same time frame from last dose to first intervention, and also the response to chemotherapy. Looking at the interventions, the first step, 30 patients in the ALPS group needed local resections, and also about the same amount in the TSH group. As you can see, after 1 week, 87% of the ALPS patients had reached their volume, but 29% also in the TSH group had reached enough volume to go for the second stage. That was half of the patients successfully treated in the TSH group. So that was much more than we expected. There were 11 days between first and second intervention in the ALPS group, but 43 days in the two-stage group. Blood values before second intervention showed that the ALPS patients were deranged. Due to this short interval, they hadn't overcome the first operation, as you can see from many of the values, but the two-stage patients had normal values mostly before the second intervention. There were more grade 3B complications in the ALPS group, but not significantly, due to deletions and wound adhesion and intestinal obstruction. The total length of stay did not differ. So, the results. The primary endpoint were resection rates, and the resection rate was 92% in the ALPS group and 57% in the two-stage hepatectomy group. There were no difference in complication, 3A and about 43%. The 90-day mortality did not differ between the groups, but as you can see, they are very high. The mortality rate for colorectal in Sweden, 30 days are 0.7 and 90 days is 1.7. So these are very, very high. Patients dying, all the patients dying, did that after the second intervention. We could not find any specifics with these patients. They didn't have increased risk points, they didn't have an increased MET score. But they were all above the 60 years of age. The patients who failed in the TSH group, all that failed due to insufficient growth went on to trying ALPPS, and 12 out of 13 did rescue ALPPS without mortality and with reduced rate of complications, only 27% of complications, which was a bit surprising. So 82% of all patients in the two-stage group were finally resected compared to 92% in the ALPPS group. So the conclusion of this study is that ALPPS is superior regarding resection rates without increasing perioperative mortality or complication. Radicality in the liver was the same, but mortality rates are very high in both groups. 50% of the successfully two-stage hepatectomy treated patients reached their volume within 1 week. And failures of two-stage seem to benefit from rescue ALPPS when it comes to resection. But there is no information from this study regarding oncological outcome. We will do the oncological analysis in the autumn for 2018. There are a few studies who have looked at oncological outcome, and probably the truest one is the one from Adam's group, looking at intention to treat and seeing that there is a worse survival in the ALPPS group. They have very low disease-free survival in both groups. The study by Ratti and Kamba had no difference, but the Ratti study showed significantly more complications in the ALPPS group. We also looked at the same thing in our patient before the Ligro trial. We looked at colorectal and see that R0 seems to be more important when ALPPS resected than when you do local resections. Also, this important study just came out from a collaboration of Europe and South America, comparing ALPPS with negative prognostic factors compared to palliative chemotherapy, showing no difference in survival between those two groups. So in conclusion, patients in need of two-stage hepatectomy or ALPPS have a severe prognosis. All other surgical options should be ruled out before you decide on this kind of treatment. A small standardized FLR, less than 70%, will need more than two-stage hepatectomy. No one of those patients passed both stages. Rescue ALPPS seems to be a valid option in failed patients, and R0 seems to be more important than in local resections. Palliative chemo may be a better option in advanced disease, and data so far indicate the same survival for the two techniques. Radiological evaluation should be performed already after 1 week, that it can be helpful in deciding how to continue. But ALPPS should be further developed to reduce complications and mortality. Thank you.